All right, so we're going to get started with a quick review of leukemia. This topic can be a little bit more tricky, so as always, I've tried to make it as clear cut and precise as possible and just stuck to the stuff that you really need to know. Just try to simplify this a bit because, like I said, it can be a little bit tricky. So let's get started with the leukemia. I always have to thank you so much. You guys are the best. The comments you leave are so nice, and I really do appreciate it. So thank you so much. And if you haven't subscribed yet, I would really appreciate it if you do. It really helps promote the channel and get the word out about it. So let's go ahead and get started with leukemia. And let's talk a little bit about what leukemia is. So leukemia, it's a progressive malignant disease of the body's blood-forming organs and cells. You're going to have abnormal proliferation and development of leukocytes and their precursors. And to put it simply, leukemia is white blood cell cancer. And that's what the word leukemia broken down means. It comes from the Greek word leukos, which means white, and hema, which means blood. So it's essentially white blood cell cancer. You're going to have different classifications depending on both the whether it's acute or chronic by the degree of cell differentiation, which is just basically the cell age. So that's your acute versus chronic, and your AML and ALL versus your CML and your CLL, the acute versus chronic. And then it's also classified by the predominant cell involved. So whether it's myeloid or lymphoid, is your ALL and CLL versus your AML and CML. So 4 different subtypes, which I'm sure you've heard of. You have acute lymphocytic leukemia, acute myeloid leukemia, chronic lymphocytic leukemia, and then chronic myeloid leukemia. There's a bunch of variations in the name. There's myelogenous leukemia, there's lymphoblastic, so a lot of different names, but these are generally the 4 names you'll hear about. So a couple things I wanted to go over first, tips slash short reviews. The first thing that I wanted to go over is how we get the name. So I wanted to go over a little bit about that. So if you have a myeloid leukemia or a myelogenous leukemia, so either AML or CML, you're looking at the cell line, basically your neutrophils and your myeloblasts. If we take a look here, we can see the different cell lines that we're talking about. So these are your stem cells. These are your baby cells in the beginning of the process. So if we're talking about AML and CML, our myelogenous or myeloid leukemias, we're talking about the myeloid stem cell. And it all depends on whether it's acute or chronic, which cell line we're talking about. So if we're talking about AML, acute myeloid leukemia, we're going to be talking about the myeloblasts. So we're going to be focused on this area here. And then if we're talking about a chronic, we're talking about further down the line. So CML is going to involve basically your granulocytes, typically neutrophil predominated. So AML and CML, we're talking about the myeloid stem cells. So we're talking about everything over here. The acute ones, again, are going to be the baby cells, the myeloblasts, and then your CML is going to go further down the line, your granulocytes down here. So just so you have an idea of that. And then when we're looking at our lymphocytic leukemias, our ALL and our CLL, we're talking about the other sides, our lymphocytes and our lymphoblasts. So now we're talking CLL and ALL, so we're talking about our lymphoid stem cell line. So this is going to be this side that's going to be affected. So ALL is going to be, again, your baby cells, your lymphoblasts. So we're talking about our lymphoblasts here. And then when we're talking about CLL, we're talking about all of our lymphocytes down here. So our B lymphocytes, T lymphocytes, our natural killer cells. Mainly the B lymphocytes are the ones that it affects the most. But again, your CLL, we're talking about further down the line here. ALL, we're talking about our baby cells, our lymphoblasts here. So just so you have a visualization of that, because sometimes the name doesn't really mean anything, so you can kind of understand which process we're talking about in the cell line. My second tip is actually a tip. The other one's more of a review. But my second tip is if the leukemia has an M in the middle, so AML or CML, the patient is most commonly going to be middle-aged. Everything I'm going to say, there's never 100% in medicine, but everything I'm going to say for the most part. So your CML and your AML, these patients are most commonly going to be seen in their 50s and their 60s. So anytime you see an M in the middle, AML, CML, be thinking of middle-aged patients. Now, when you see a CLL or ALL, you see a leukemia that has an L in the middle, you should be thinking of your extremes of age. So that L is going to mean either really old or really young. The way that I used to I'll give you some tips as I go through to remember them, but I used to remember that ALL, the L in that stands for little, because this is the most common malignancy seen in childhood. ALL is kids. And then the L in CLL stands for long in the tooth, aka old, because CLL is going to most commonly be diagnosed in patients in their 70s. So you see the M in AML, CML, be thinking of middle age. You see CLL or ALL, think those extremes of age. CLL, old patients, ALL, kids. That's what you should remember when you see those, because that's going to help you out in the vignette. All right, so let's get started with our first one. We'll start with acute lymphocytic leukemia, also known as acute lymphoblastic leukemia. Um, this one, as we see, it has an L in the middle, so we know it's an extreme of age. We know they're either going to be little or they're going to be long in the tooth. I'll give you a way to remember which one that is in a second as I go through this. So first, this is an acute leukemia of lymphoid precursor cells in the bone marrow, like we went over before. That cell line when we looked at that. B cell is going to be the most common subtype, about 85% of the cases. And then here is your very important, that's why red and underlined, this is the most common childhood malignancy. When you see a vignette and it has a kid and they're speaking of leukemia, it's going to be ALL. I promise you that's who they're going to give you. Most common childhood malignancy, you cannot forget that. It's very important. Again, if you see a vignette, it's a kid, and you feel like they have cancer, they're giving you those signs, it's going to be ALL. The way that I used to remember that is there is a soap opera, hopefully you've heard of this. It was pretty popular, it was around for like 20, 30 years, and it was called All My Children. So this works out really well because you have your ALL right there, because acute lymphocytic leukemia, so there's your ALL, and then you have children. So All My Children, remember, most common malignancy in children, right there. That's how you remember. Anytime you see ALL, be thinking of All My Children, that soap opera that maybe your mom watched or somebody, I don't know. Remember All My Children. Hopefully that'll help you remember it. I always remember that. So most common malignancy in childhood. Clinical manifestations. As we go through these, you're going to see there's a lot of overlap with the leukemia. These aren't really the most high yield part of this, but let's kind of run down each one because some have some unique things about them. So in ALL, there's really 5 clinical manifestations that are going to be seen in most patients with acute lymphocytic leukemia. Most children are going to have at least one of these manifestations at presentation. So the first one is hepatomegaly, splenomegaly. So these are the most common clinical manifestations in children with ALL. About 64% are going to have hepatomegaly on presentation, and about 61% will have splenomegaly on presentation. Lymphadenopathy is another one, seen in around half the patients with ALL. Fever. This can either represent a constitutional symptom of leukemia, or it can just be caused by an infection from the compromised immune system. So either way, about half the kids with the diagnosis are going to have a fever. I keep saying kids. It's possible that ALL can be in older people too, in adults, but generally, again, kids. So that's what you should be focused on. Hematologic abnormality. So this is kind of broad, but you, because of the anemia, the thrombocytopenia, they can have petechiae, purpura, manifestations of anemia like fatigue, pallor, things like that. And then finally, musculoskeletal pain. So they may come in limping. They may definitely mention that in the vignette. They may not want to bear weight. It's less common than some of the other manifestations, but it's still seen in around 40% of kids with ALL. The bone pain, of course, is due to the proliferation in the bone marrow. So those are the main clinical manifestations that you're going to see in acute lymphocytic leukemia. The way that I remember that is acute lymphocytic leukemia, ALL, stands for anemic, lumpy, and limping. So anemic, of course, that pallor, petechiae, purpura. Lumpy because they have lymphadenopathy, hepatomegaly, splenomegaly, they're lumpy. And then limping because, like I mentioned before, the musculoskeletal pain. The only thing missing from there is the fever, which again can be seen in other things as well. So you remember, ALL stands for anemic, lumpy, and limping for the presentation these patients are going to have. Now, diagnosis. You're going to start with your CBC, which is going to be the initial test in all of these. Anytime you suspect leukemia, you want to get your CBC with differential, with smear. And what you're going to see is pancytopenia. So that means the whole CBC is effed up. Everything, your platelets, your white blood cells, your red blood cells, everything's effed up. Pancytopenia, all of the cell lines are messed up. So the main things you're going to see, anemia, thrombocytopenia, and I say white blood cell derangement because the white cells likely are going to be high. Leukocytosis is found in about 50% of patients, but your white cells can actually be normal. They can be low in acute lymphocytic leukemia. So generally just remember the white blood cells are going to be off. But anemia and thrombocytopenia are going to be found in most patients. So that's really the main things you need to focus on. And again, your white blood cells are going to be off, but they may be low, they may be high, and it's possible that they could be normal. So just kind of know that. Not so important for your questions, but just for real life. And then you do the best test. This is going to be your bone marrow biopsy. This is the key to your vignette. This is really what's going to give you the answer to the question. And what you're looking for is 20% lymphoblasts. That's your key, greater than 20% lymphoblasts. That's going to be in the vignette for sure, and you need to know that. You'll see lymphoblasts on the peripheral smear, and then you confirm it on bone marrow biopsy. So again, you're looking for over 20% blasts. Blasts, remember, are those immature baby cells. So we can look again here at remember we're talking about the lymphoid stem cell line. So we're talking about our lymphoblasts. This is an acute lymphocytic leukemia. So we're talking about these guys here. And this is what's going to be affected. That's what you're going to see. So over 20% lymphoblasts, that's what we're focused on when we see ALL. Now treatment. For treatment, really with all of these, with a couple exceptions that I'll go over later, you're going to use chemo, but don't worry about your different agents. Don't worry about the specific chemos you'll use. I mean, this one you use vincristine combined with corticosteroids. There's a bunch. Don't memorize it. It's highly unlikely you're going to get tested on a specific type of chemo. The only thing I want you to know about the chemo treatment in patients with acute lymphocytic leukemia is that you're going to need to prophylax the CNS. So these patients, you do that with intrathecal methotrexate. So ALL can infiltrate and hide in the CNS. And because of this, you have to prophylax the CNS. You do this with intrathecal methotrexate. Before they started with CNS prophylactic therapy, close to 80% of children who had ALL that were in complete bone marrow remission would wind up with a relapse with leukemic meningitis. So this is really important to their therapy, and it's one thing that you need to know about the treatment. Treatment for these vignettes isn't very important, again, because they're not going to mention all the different types of chemo, but there's little things that you need to know like this. So remember, ALL, you need to know that you're going to prophylax the CNS, and that's generally going to be with intrathecal methotrexate. So the things that I feel like you need to know that you need to take away here, if you're going to forget everything else, remember, this is the most common malignancy of childhood. You need to know that. You need to know on your bone marrow biopsy, you're going to see over 20% lymphoblast. Remember your clinical manifestations, fairly important. Remember your ALL, anemic, lumpy, and limping. And then remember, for treatment, you need to prophylax the CNS. So that's going to be with intrathecal methotrexate. All right, so let's move on to our next acute leukemia. That's acute myeloid leukemia or acute myelocytic leukemia. Now this has an M in the middle, so we know they're going to be middle-aged. Again, remember your 50s, 60s, around there. This is the most common type of acute leukemia in adults. And there's a few different subtypes. There's only one super high yield one that you need to know. There's a few different subtypes again, but there's only one that you really need to know. You have to know this one. It's called acute promyelocytic leukemia, also known as APL, also known as the M3 variant. You need to know three things about this APL, this M3 variant. Three things are myeloperoxidase, ARA-C, and vitamin A. So first, myeloperoxidase. So these patients, if it's acute promyelocytic leukemia, this variant, it's going to stain positive for myeloperoxidase. So that could definitely be in the vignette to kind of lead you to this variant. Second one, this is by far the most important, probably like the top three of everything in leukemia, ARA-C. So these are needle-shaped, these pink needle-shaped structures that stick out of the cytoplasm. You need to know that as soon as you see ARA-C, right away you should be thinking of acute promyelocytic leukemia, this variant of AML. So this is what they look like. They're these little kind of things stabbing out of the cytoplasm. So if you get like a microscopy image like this and they're mentioning leukemia, it's probably going to be an ARA-C they're showing you. So just remember that this is what an ARA-C looks like. An ARA-C again is seen in acute promyelocytic leukemia. And how do you remember that? Well, this is how you remember it. Hopefully you've heard of Alex Rodriguez. He was a player for the New York Yankees. He dated J-Lo for a while. I don't know anything about baseball, but I know A-Rod played for the Yankees. So hopefully you know about that. So the way that I used to remember that, A-Rod, Alex Rodriguez, also A-Rods, plays for the New York Yankees in the Big Apple, which is acute promyelocytic leukemia. So as soon as you see ARA-C, think of A-Rod played for the Yankees in the Big Apple, acute promyelocytic leukemia, and hopefully that will lead you to the right answer. Hopefully you can remember that. Again, I know nothing about baseball, but I know who A-Rod is. I know he played for the Yankees, and obviously the New York Yankees, Big Apple. Hopefully you can make that association. All right, so that's a really high yield one. You do need to know that. And then the last thing, if you do see that they have this variant, they have the APL M3 variant, you need to know that in addition to their chemo regimen, you're also going to treat them with vitamin A, also known as all-trans retinoic acid. So they have to be treated with that in addition to their chemo if they have this subtype. Clinical manifestations, again, this is not the highest yield part of these things, but let's go over it. So patients with AML are usually going to present with symptoms related to complications of pancytopenia, like we saw in ALL, and really most of these. So anemia, neutropenia, thrombocytopenia, most common symptoms that you're going to see. Fatigue presents in the majority of patients. It may precede the diagnosis by a number of months. Pallor weakness, this of course is related to the anemia. Infection, because of the neutropenia these patients may have. And then you'll notice that all of our lumpy symptoms that were in ALL, hepatomegaly, splenomegaly, and lymphadenopathy, they're rare in AML, so you don't really see that in these patients. Now, going to our diagnosis, again, we're going to start with our CBC with diff. And again, we're going to see pancytopenia. Everything is messed up. So you're going to see thrombocytopenia, you're going to see anemia, you're going to see neutropenia. Thrombocytopenia is really the most common finding that you'll see on CBC, so low platelet count, and it's seen in almost all patients with AML. So that's your CBC, nothing really high yield there. High yield is going to be in your bone marrow biopsy. So again, remember this is acute, so we should be thinking of our blasts, our baby cells, and we're talking about the myeloid line. So what are we going to be looking for? We're looking for myeloblasts. So just like in ALL, you do a smear, you're definitely going to see circulating myeloblasts. So you can do your smear first and you see those myeloblasts, but you always have to do a bone marrow biopsy to confirm the diagnosis. And again, you're looking for 20% myeloblasts, which will confirm the diagnosis. And again, let's take a look here. So this is acute, just like before with ALL, we were looking over here because it's ALL, lymphoid stem cell line, but now we're talking about acute myeloid leukemia. So we're talking about this side, and we're acute, so we're talking about our baby cells, we're talking about our myeloblasts, so we're in this area here. So that's what you're going to be looking for on bone marrow biopsy, over 20% myeloblasts. That is what you definitely need to know. Now treatment, again, chemo. You're going to use chemo, we know that in all of these. But what you need to remember is that if it's the M3 variant, the APL, you need to add on that vitamin A, that all-trans retinoic acid. So that's what you need to know about that. These are your three need to know. So you have to know about acute promyelocytic leukemia and the association with ARA-C. Got to know that. You have to know you're going to see over 20% myeloblasts on bone marrow biopsy, and then be aware that your regimen is going to include vitamin A, all-trans retinoic acid, if it is the APL subtype. Those are your three main things I would say you should remember. All right, moving down the line. Chronic lymphocytic leukemia. So of all the leukemias, this is probably the one you need to know the least about. There's really just a few things that I think you should be aware of on this one. So this is going to be a mature B cell neoplasm that involves a progressive accumulation of monoclonal B lymphocytes. It's a mouthful, technical terms, but really it's just a fancy way of saying we got a crap load of defunct or incompetent B cells. You got a bunch of B cells that aren't doing what they're supposed to. Now, what you need to know about this, absolutely, this is going to be an older adult. Remember, this is one of your L's, your CLL. Remember, long in the tooth. So this is going to be older adults. Median age of diagnosis is going to be 70. It's mainly a disease of older adults. Increasing age is one of the biggest risk factors. So remember that L, long in the tooth, in your vignette, looking for an older patient, 70 or 80s. That's really important. Now, clinical manifestations. This one is important. The fact that majority of patients with CLL are going to be completely fine. This is going to likely be an incidental finding on routine CBC displaying lymphocytosis. Most of these patients are going to be asymptomatic. They come in their office for a routine follow-up at their primary care, they get a CBC done, and then, wow, all of these white cells, what's going on? And then you make the diagnosis. Most of the time, these patients aren't going to have symptoms. A small number of patients may have some of those B symptoms like fever, night sweats, fatigue, around 5% of patients. And then just like in ALL, so fatigue again, remember it's one of those symptoms, just like in ALL, these patients are going to be lumpy on your physical exam. So they're going to have lymphadenopathy, splenomegaly in about 30 to 50% of patients, and then hepatomegaly in about 15 to 25% of patients. So remember, CLL and ALL patients are going to be lumpy. But overall, CLL a lot of times is going to be an asymptomatic patient with an incidental finding on blood work. Now, as far as diagnosis, again, what are we going to start with? We're going to start with our CBC. We can do a peripheral smear. There's really two things that you need to know for the diagnosis in CLL, and that's going to be lymphocytosis and something called smudge cells. So on your CBC with your peripheral smear, you're going to see lymphocytosis. Absolute lymphocytosis is what it's known as, the correct term, absolute lymphocytosis. It's over 5,000. That's the most important laboratory abnormality found in CLL is lymphocytosis in the peripheral blood. So the threshold for diagnosis is over 5,000, but a number of these patients with CLL will have counts as high as 100,000. So really high lymphocytes, really high. And again, we're talking about CLL, so we're talking about our lymphoid stem cell line. But remember, this isn't acute, so we're past the lymphoblast. We're down into this area here. And most of the time it's going to be predominated by your B lymphocytes, but it can be your T lymphocytes, your natural killer cells. But most of the time it is predominated. It is mostly your B lymphocytes. So remember, we're talking about chronic, so we're talking about further down the line. Again, mostly your B lymphocytes. So lymphocytosis, absolute lymphocytosis, really high counts in these patients. And then the second thing you should know of is something called smudge cells. So this is a hallmark finding in CLL. All smudge cells are a lab artifact. They're lymphocytes that are smeared out in the process of being spread on the glass slide for microscopy. When they put the little cover slip over the top, this is what you're going to see, because the CLL cells are more fragile than normal lymphocytes. So they put that cover sheet or that little covered piece of glass on the microscope, and then they take a look and they see all of these cells that are just smudged. They're just smushed all over. So it seems like such an insignificant finding, but it's really pathognomonic for CLL, and you have to know that. It's going to be in your vignette. I know I had a question in school about it. It seems like something minor, but it's one of those things I really like to mention in vignettes. So really remember smudge cells, and the way that I have for you to remember that is to remember that CLL stands for crushed little lymphocytes. Isn't it perfect that the name has those 3 perfect letters? So crushed little lymphocytes. Remember, smudge cells seen in CLL. So if you see a vignette, you see smudge cells, you're like, which one is that again? Just remember crushed little lymphocytes, CLL, and I'll help you remember that. That is an important thing. You do need to know that. Now, treatment. What's important here is that if these patients are asymptomatic, a lot of times you're just going to observe and do nothing. Generally, if they're older, like over 65, they're not having symptoms, observation is really the treatment of choice. CLL in older patients is often something they're going to die with rather than from. It's similar to prostate cancer in older patients. A lot of times it's not treated because the side effects and all the adverse effects from chemo are worse than the actual disease itself, and a lot of times it has this indolent course where these patients don't really feel that bad, and a lot of times it doesn't cause their death. It's something they die with, not from. So remember, if they're older, they're asymptomatic really is the basis for this. You're just going to observe. Now, if they become symptomatic or they're younger, chemo, of course, is going to be your option. And then there's also stem cell transplant. Stem cell transplant is another option for some patients that can potentially tolerate it, and it can be curative in these patients. But remember, generally, CLL, a lot of times you're just going to observe. Things you need to know: patient is going to be old. Again, nothing 100% medicine. The patient could be 40, but remember, on your vignette, they're going to be an old patient. They're going to be in their 70s, their 80s. Remember those smudge cells. That's really important. And then remember, you're just going to observe if they're asymptomatic. Moving on to our last one, chronic myelogenous or chronic myeloid leukemia. So there's a few high yield things in this. So first, we see CML has an M in the middle. We know this patient is generally going to be middle-aged, 50s or 60s, what you're looking for, for the most part in your vignettes. This is going to be a myeloproliferative neoplasm with uninhibited proliferation of granulocytes. So let's break that down into words we can understand. So the hallmark of CLL is this uncontrolled production of granulocytes, mature and maturing granulocytes, predominantly neutrophils. So that's the one you're looking for. It can involve basophils, eosinophils, the other granulocytes, but the main thing to remember, generally you're looking for a crap ton of neutrophils in this type of leukemia. That's the main thing that you would look for in CML. Now the patho, this is really important, and this is why I'm mentioning patho in this one. This is like probably the second highest yield besides your ARA-C and those types of things, but this is really important. So a reciprocal translocation between chromosomes 9 and 22 is going to give a rise to an abnormal chromosome called the Philadelphia chromosome. So a 922 translocation and the Philadelphia chromosome, you have to know this is associated with CML. It's super high yield, committed to memory. If you forget everything else about CML, remember Philadelphia chromosome and 922 translocation. I'll give you a way to remember it at the end, but try to remember that. Clinical manifestations, up to 50% of patients can be asymptomatic. It's going to depend on the stages. So there's a few different stages with CML. There's the chronic, accelerated, blast crisis. Manifestations are going to be different for each stage. Don't memorize the stages, but just be aware they can present differently depending on what stage they're at. So again, remember, asymptomatic in about 50% of patients, depends on which stage they're in. Splenomegaly is a big one. You actually see this in about 75% of patients with CML, so it's very common. They also might have left upper quadrant pain, fullness due to the splenomegaly that they're going to have, which is pretty significant. Fatigue, weight loss, fever are all positive. Again, these aren't really very specific, but just know some of those things may present in the vignette or in real life when you're seeing patients. Now, diagnosis, what are we going to start with? We're going to start with our CBC. You're looking for two things. So you're looking for leukocytosis, or really you're looking for one thing with this specific variance in it. So leukocytosis, your white count is going to be approximately 100,000, so really high white cell count. But what you're going to see in this, you're going to see a neutrophil predominance. You're going to see neutrophilia. So you can have an elevation in any of your granulocytic cells, so your basophils, your eosinophils, but most of the time when you see CML, especially for a vignette, they're going to give you a neutrophil predominance. So you're going to see that neutrophilia. So remember, again, we're talking chronic and we're talking myelogenous. So we're talking over here and we're talking chronic. So let's move down the line here. So we're focused on our granulocytes. Anything can be affected though here. Your red blood cells can be affected, your platelets, but mainly in CML, we're going to focus on our granulocytes, and then we're going to narrow it down even further to our neutrophils. So again, most of the time you're going to see neutrophilia. So a lot of neutrophils in CML. So that's what we're going to be looking for in the vignette. And that's what you'll look for in your CBC. Now, treatment, this one is important. All the other ones I said don't worry too much about treatment except those little variations. Treatment for this one's really important. And this is going to be tyrosine kinase inhibitors. Specifically, imatinib is what you normally start with. So the reason why I feel like you should know the drug that's being used is because it's unique in CML. So let me explain. Going back to the Philadelphia chromosome we talked about earlier, that 922 translocation. So this translocation is caused from a tyrosine kinase overexpressing. It's causing this cancer. So wouldn't it be nice if we had a drug that specifically targeted that overexpression, that translocation? Well, that's what imatinib is. Imatinib isn't just some general chemo drug or, tyrosine kinase. It was specifically made for CML. In the late 90s, they found and they worked on making this drug specifically to target the overexpression we see in CML. So the drug was literally made just for this. And that's why it's so important to know, because they likely will ask you that. So imatinib was the first targeted therapy we ever had for cancers. It's still a good drug, but there's some newer tyrosine kinase inhibitors. But definitely remember imatinib, because that's usually the drug you start with. And when the other ones fail, you switch to the newer agents. This is a great drug, but most of the time, eventually it will fail and then you need further treatment. But it's important to know, because in the vignette, if they give you a question, you're going to have to know this is where you're going to start with your tyrosine kinase inhibitors, and normally your imatinib. I'd be familiar with that. So there's a few important things you should know for CML. How are you going to remember that? Well, I have a little tiny story for you. Not very long, but what I want you to remember is that Tyrone is a country music lover, and he's really excited to go to a country music concert that happens to be in Philadelphia. But on the country music concert was scheduled on 9/11. Unfortunately, tragedy struck that day, and the concert was postponed to 9/22. So Tyrone, tyrosine kinase inhibitors, remember your first line therapy, country music lover, CML, was excited to go to a country music concert in Philadelphia chromosome. It was scheduled on 9/11. Unfortunately, tragedy struck that day, and the concert was postponed to 9/22 translocation. So remember about Tyrone, country music lover, went to a concert in Philadelphia, got postponed to 9/22. You can remember those important things that you need to know about CML. All right, so that's leukemia. Not too bad. Let's do 5 quick questions, and then we will be done, and you can wrap that up. So 57-year-old male presents to the office today complaining of fatigue and weakness over the last few months. On exam, splenomegaly is noted. A subsequent CBC and bone marrow are performed, and it is discovered that he has chronic myelogenous leukemia. What class of medication will this patient likely be started on? Well, luckily we just did that one. So remember, Tyrone, country music lover, Tyrone, tyrosine kinase inhibitor, so that's going to be your imatinib. Question 2. 7-year-old boy presents to the office accompanied by his mother. She states he has been excessively tired for several weeks and has had a persistent fever that just does not seem to be getting better. On exam, ecchymosis is noted on both upper and lower extremities, as well as hepatomegaly. CBC is performed that shows pancytopenia. Bone marrow biopsy is ordered, which displays over 20% lymphoblasts. In addition to starting chemotherapy for this patient, what additional treatment option is necessary for the likely diagnosis? So again, start thinking of what diagnosis he has and what do you need in addition to the chemo. You're going to do CNS prophylaxis. This is ALL. Remember, this is a little kid. He's lumpy. He's got that splenomegaly or the hepatomegaly. He has those hematologic abnormalities. You can see the ecchymosis on the legs. He's had the persistent fever. And then, of course, none of that matters because it showed 20% lymphoblasts. So we know right away we're talking about ALL. And remember, in addition to chemo, you need to prophylax with chemo in the CNS. Question 3. Specimen is sent to the lab for analysis. When the specimen is placed on the slide and a cover slip is applied, on visualization the cells appear to be smudged or damaged. Which type of leukemia most commonly displays this type of abnormality? So hopefully you remember your crushed little lymphocytes. That's going to be chronic lymphocytic leukemia, CLL. Question 4. The Philadelphia chromosome is caused from a translocation between what two chromosomes? Well, what day did Tyrone go to the concert and then it got postponed? It's going to be 9 and 22. So remember, 9/11 was the concert, got postponed to 9/22. All right, last question. The presence of Auer rods and myeloperoxidase positivity should raise suspicion for which leukemia subtype? So remember, do not forget that one. That is going to be your acute promyelocytic leukemia, which is a subtype of AML. And remember, as soon as you see Auer rod, be thinking of A-Rod playing for the Yankees and the Big Apple, APL, acute promyelocytic leukemia. All right, that is leukemia. I hope that helps you. Please let me know in the comments if it did, and any other comments or suggestions you guys have for me. I will certainly appreciate that. Thank you so much for listening. Good luck on your PANCE, your PANRE, your EORs, and good luck in PA school.